welcome everyone. The first business I gotta take care of is I'm gonna put myself to the Budget and Finance Committee since I'm not on this committee, but as a chair I can do that, so now we have a quorum. All right, good evening. Today is May 22nd, 2019, and it is 5:32. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Board of Managers Budget and Finance Committee. Items 8 and 10 will not be discussed tonight, and those items are 8, discuss and take appropriate action on the Central Health owned or occupied real property, including the downtown campus, and properties included in eastern Travis County. 10, discuss and take appropriate action on the update regarding Sendero Health Plans, Inc., including the effects of federal, legislative, and regulatory actions. Next, the agenda items will be taken in the following order. 1, 5, 2, 3, 9, 4, 6, 7, and 11.
Repeat those, Chair, please.
Repeat them? Okay, sure, no problem. So they will be taken in this order. 1, 5, 2, 3, 9, 4, 6, 7, and 11. Got it? Okay. Agenda item 1, consider and approve the minutes of the April 17th, 2019 meeting of the Central Health Board of Managers and Finance Committee. An action item. So, has everybody read the minutes? Member Valadez.
I move that we go ahead and approve the minutes for the April 17, 2019 meeting of the Central Health Board of Managers. I'm sorry, Budget and Finance Committee.
Second.
So we have a motion on the floor by Manager Valadez, seconded by Manager Greenberg. All in favor say aye. All against say no. Motion passes. All right. Agenda item 5, discuss and take appropriate action on Central Health's proposed fiscal year 2020 homestead tax exemption for Travis County residents over 65 or disabled. Miss Lisa, well, Jeff, you're not Lisa.
Jeff Knoedel, CFO, Central Health. Every year during our budget process, one of the very first things that we do, well before we even set the property tax rate, is we look at the exemptions that are in existence related to Central Health. There are a lot of exemptions. A lot of the exemptions are state mandated and have state limits. There are a couple of local exemptions. Those exemptions, as it relates to Central Health, include homestead, over 65 exemption, and a disability exemption. Travis County, the Commissioners Court, has the final authority as to what our exemption amounts are. We typically bring these forward to the board, ask your consideration, and send a recommendation to the board. We had a memo in the packet, the board packet, that looks at all the current exemptions for the taxing jurisdictions in Travis County. Typically, we have had the same rates as Travis County on the homestead exemption, which we have a 20% exemption, which is the maximum amount allowed under state law. And then both our over 65 homestead exemption and our disability exemption are the same as Travis County, which is currently $85,500. Typically, the Central Appraisal District requests that we get this information, the final exemption information, to them no later than the end of June. So we're bringing this forward for any discussion and or consideration, but I do want to be mindful that we will need to send a recommendation to the Travis County Commissioners Court and get that on the agenda, and then that information would have to be sent prior to June 30th. So we're bringing it forward tonight. Staff is not recommending any changes, keeping the homestead exemption the same. and the over 65 homestead and disability exemption the same. And that's reflected in the memo. And again, you see the other taxing jurisdictions in the memo. I'd be more than happy to answer any questions that the committee may have. And I'll turn it back over.
So this is an action item, I need a motion. Manager Valdez.
I go ahead and move that, but I'll have a question. Just
I'm
clarification.
Sorry,
with
just to be clear.
Let's make the motion first. and then
Okay,
we
that's
can-
what I was gonna do.
then we can have-
It's page 43 in the packet agenda. Sorry,
Thank you, Jeff.
should have pointed that out.
I move that the committee recommend the board approve maintaining the current Central Health Homestead tax exemption of $85,500 for Travis County residents over 65 or disabled for the fiscal year of 2020.
Second.
Okay. So I have a motion on the floor by Manager Valdez, seconded by Manager Greenberg. Now, is there any discussion or questions?
The only question that I had for clarification purposes, is this going to require an individual vote or is just a regular majority?
Should we-
No, It's a,
Because
it's
it went,
a,
because
it's a,
it was dealing with the property tax rate.
right, typically the rate's done individually. The exemptions are done by the board as a whole.
Okay.
And again, it's a recommendation to the commissioners.
That's fine.
court.
In lieu of no other
Any other
discussion,
discussion? Manager Jones, you have any discussion? No? All right. Would you choose to abstain this year, or? Okay, all right.
You get to that point, I was gonna.
Yes. All right, just want to make sure I asked that question. My apologies. All right, all in favor say aye.
Aye.
All against say no. Any abstentions? Does the record show that Manager Jones is abstaining? Thank you, Manager Jones.
Thank you.
Motion passes. All right, agenda item 2, discuss and take appropriate action on the relocation of operational cost savings within the Community Care Collaborative's fiscal year 2019 budget for an increase in the post-acute care budget related to skilled nursing facility services and a corresponding amendment to the contract for physical therapy specialists. This is an action item as well. Mr. Morgan, thank you for coming.
Thank you, sir. Good evening. I would like to first call your attention to page 8 of your packet. There was a pretty extensive memo that was included in the read-ahead. There's been some corrections made to that memo, so if you've got the earlier version, I'd ask that you refer to the one in your packet tonight. There are a few errors in the prior memo. The purpose of me being here this evening is to request approval from the board as a member reserve power through the CCC bylaws to reallocate some funds in the CCC budget. If you recall, going back to the beginning of our budget process, we had a pretty tight budget overall. We're trying to put every dollar that we have available to us to use in the system. And what we committed to, knowing that we couldn't fully fund all of the areas that we wanted to, was that as we proceeded through the year, we would come back to the board and ask for reallocation so that we could fund areas that we knew we were going to need to. Post-acute, if you recall, I was here in March, and this board approved an amendment to our budget related to the front steps part of our post-acute service area. Tonight, I'm here to ask for reallocation of $600,000 of our operational expenses to fund additional post-acute through our skilled nursing facilities. So it's kind of the other half of the post-acute care network for us. Front steps, we increased by $500,000 for a total of $800,000. Based on the way that we contract in post-acute, we started the year with $200,000 available for the skilled nursing facilities. Applying $600,000 more at this point will allow us to contract with that group of providers up to a not-to-exceed amount of $800,000. As you all know, we started this work through our partnership with Seton Healthcare Family, working with the health plan. They helped us gain early access to these facilities, and we have since transitioned those to be direct contracts. It's a pretty dynamic part of our budget. The provider network changes quite a bit based on capacity and quality that we see in the facilities that we admit our patients to. Right now, we have 4 facilities that are in network with us, and we intend to contract with 2 others before the end of this year, just to make sure that we have the capacity, the bed capacity that we need to meet our patients' needs. As part of your packet, we've included some information about the utilization, and then some of the high-level demographics related to the patients that are using those services. Moving on to the second part of the memo, we're requesting additional funding for physical therapy services. Again, this is a fairly new service line for us. We started it 2 years ago, and it's grown quite well over the past couple of years. We're excited to see the level of utilization that we're seeing today for physical therapy services through a contract with Texas Physical Therapy Specialists. We started out the year with $100,000 of budget authority as part of our musculoskeletal service line budget. Earlier this year, we increased the level of funding available to $200,000 under administrative authority. And now at this point in the year, we expect that our end-of-year estimate is just shy of $400,000. So we're trying to allocate an additional $200,000 to that contract. So we would be increasing from $200,000 now to $400,000. And then to try to clean that up from a budget standpoint, we're actually asking to reallocate $300,000 towards that line item in the budget. A lot going on there, a lot of moving pieces. I'm happy to answer any questions that you have.
Just a couple of quick questions. On the post-acute care skilled nursing facility services,
Yes, ma'am.
I see recuperative, skilled nursing, hospice, new initiatives, respite care, and home health.
Yes, ma'am.
I know when I look at the older patients in here, a very common situation would be, for instance, breaking a hip or things along that line. And I see you have physical therapy, but that looks like this is physical therapy that is outside of a
In-house treatment.
in-house, where you are living inpatient. Yeah, thank you, inpatient. So, do you provide any acute rehab as far as PT and rehab in these skilled nursing facility services?
Absolutely. Therapy is a large part of what happens in those facilities. It is a different level of therapy. The physical therapy.
Yeah, it's not acute
contract-
rehab. It is not at that level.
That's correct. And the physical therapy contract that we're speaking of here is actually what's referred in directly from our primary care providers. So
Okay, so
versus someone that's coming out of an acute facility, going into the post-acute network, and they receive, the majority of those services are wound care and different types of
So-
physical therapy as well.
So my question is, we have a patient who, for whatever reason, has had surgery of whatever kind, let's say, and needs physical therapy, but inpatient. Do any of our patients get acute rehab, or are they all going to skilled nursing? And when they go to skilled nursing, what level of physical therapy are they getting in the skilled nursing? Because the physical therapy that I see over here, I think, is outpatient.
Yes, it is. So the physical therapy contract is outpatient. And
Right.
It's really just based on the needs of the patient. There's certainly inpatient rehab and therapy that takes place in the hospital. If we have patients that are staying at a hospital, Seton actually contracts for LTAC facilities, the long-term acute care facilities. So patients that need that level of care would be going to a provider like Cornerstone. Post-acute is for a shorter length of stay.
Yeah, the acute
generally.
rehab in the
But
hospital.
there is rehab that takes place in the post-acute facilities as well. And then the physical therapy contract is, to your point, is office-based or outpatient therapy
Okay, but
from primary care.
I'm probably not doing a good job of explaining my question.
Yes,
And
ma'am.
my question is this: there are different levels of rehab that patients get after surgery. There's an acute rehab that is a higher level of rehab and therapy than you get in skilled nursing.
Yes.
Do any of our patients get that, or is that something that we do not
That is
provide?
not something that the CCC contracts for, but today, if patients need that higher level of rehab or therapy, it's going to take place inside of a Seton facility most of the time.
And they could get it. I mean, they have to be up to it. They have to be up to doing 3 hours, but
That's correct.
But if it's needed and they're up to it, then our patients can get that within a Seton
Yes, ma'am.
acute rehab unit, I'll call it.
Yes, ma'am.
Okay. Other patients that either don't need that level or may not have the ability to do that strenuous of a level of rehab would go to skilled nursing.
Correct.
And would they get physical therapy while they're in the skilled
They
nursing?
get physical therapy in the skilled nursing facility. There are different levels of care.
Right, I
Typically
understand.
6 different levels. And
Okay.
based on the intensity of the
Okay.
services that they're receiving, they would get those in the SNFs.
Okay, thank you.
Yes, ma'am.
All right, let's take a motion. Let's get a motion on the floor first.
Manager Zamora, if you wouldn't mind indulging me, managers, your motion sheet shows an incorrect figure in number 2, Roman numeral 2. It says $200,000. The request here tonight is $300,000. So before you make your motion, please
Fix the
correct that.
typo.
Thank you.
If I could clarify, so the additional amount of contract authority, we have to distinguish between contract authority and the budget reallocation. So the additional amount of contract authority for Texas Physical Therapy Specialists is $200,000. The reallocation of the budget for physical therapy and musculoskeletal is $300,000.
So
Makes sense?
do you want the $200,000?
I don't have the motion
I'll show
language.
you.
Is the motion language referring to the contract authority? So the contract authority is for $200,000.
Okay, you rewrite it for us, John, so we can get it correct.
So it's actually correct on your motion sheet according to what Mr. Morgan just.
100 is
It
correct.
reads correctly for the contract authority.
Okay.
Do we need to add with the reallocation amount being 300,000? No? Okay.
Sorry about that.
That's fine.
Better to be cautious.
Thank you, Council. Manager Valdez?
I move that the committee recommend that the board approve and direct that Central Health appointees to the Community Care Collaborative Board of Directors approve I, small Roman numeral, the reallocation of operational cost savings within the Community Care Collaborative's fiscal year 2019 budget in order to increase the post-acute care budget for skilled nursing facility services by $600,000. And small Roman numeral 2, further move to amend the existing contract with Texas Physical Therapy Specialists to increase the compensation available by $200,000. Is that correct?
Yes, ma'am. Thank you.
For your second. So I have a motion on the floor by Manager Valdez and seconded by Manager Oliver. Any other further discussion? Manager Valdez.
I just wanted to follow up just to the last part of the question that Sherry had asked with respect to physical therapy being provided in the facilities, off-site, and I just wanted to, I was curious as to, if needed, if there are those that need that physical therapy, and they really do have that need, but they cannot necessarily get to that site, is there transportation accommodations, or is there therapy, physical therapy allowed by the home health care provider at the home?
Today, we don't do home-based physical therapy. I think
Okay.
that's something that we're interested in and
Yes.
Yeah.
certainly looking at. We do have multiple transportation options because that has become a problem. Fortunately, Texas Physical Therapy Specialists has multiple facilities, I want to say 12 in Travis County. And they're really centered along the I-35
35 corridor.
corridor. So we do try to use our transportation resources, be it ride share, bus passes, taxi vouchers, whatever makes sense for the patient to get them there.
So are you telling me that there are no facilities located east of 35 or within the Eastern Crescent?
I don't believe so for Texas Physical Therapy Specialists.
Okay, so you do know that if they do have that great need for physical therapy, they may not even necessarily be able to get into taxi or whatever, but that accommodation is going to be made for them?
It is, and we've actually been pretty successful with getting our patients into physical therapy. That was a concern we had going into it. We're seeing anywhere from 7 to 10 physical therapy visits on average with this provider, and we're happy to see that high rate of utilization. It means we're actually getting our patients in the door.
And then one last question. With respect to the inclusion of the words, the addition of respite services through a local boarding home,
Ma'am?
where's that home located?
There are actually 2 or 3 different facilities. I don't have the exact locations, but I can get those for you.
Thank you, Ed, but what is,
That's a new initiative, so
Okay, so-
it's not turned on quite yet.
so what are you calling respite services?
So this is really, it's boarding home services. So
Okay.
this is for our homeless patients that really need a place to recuperate, but they don't have a skilled need.
Stable place.
Yes, it's a stable place. It's usually short-term, probably 2 to 3 weeks,
Thank
in
you.
order to recuperate.
Great, Jonathan. Okay, no,
Vice Chair.
No, I would just like to add my support to having some type of service for those who truly need it, where they can receive in-home physical therapy, because the concern about falling for some of these patients as they're trying to get to a physical therapy appointment, they're at great risk of a fall, which could put them back into the hospital, and we know what that is. So I encourage that. Thank you.
Any other questions? All right. So we have a motion on the floor. So all in favor say aye.
Aye.
All against say no. Any abstentions? Motion passes. Thank you, Mr. Morgan. Thank you for your time. Okay, I'm going to use the chairman's prerogative and again change the order of the agenda. We're going to move agenda item number 9 up next, so we can bring Mr. Cardillo in. Agenda item 9, discuss and take appropriate action on the 1115 Medicaid waiver delivery system reform incentive payment, DSRIP projects, the community care collaborative, including the health care delivery arrangements and other community partnerships, which discussion will include a possible presentation by Mr. Craig Cardillo, President and CEO of the Ascension, Texas. Mr. Cardillo, thank you, Craig.
Yeah, thank you, Chairman, Dr.
thank you.
Zamora. I appreciate being
Thank you.
able to be here. The introduction as described is probably a little bit more formal than what your expectations will be for today. And so I appreciate being able to be here in front of the Central Health Board. I thought I'd take a few minutes to describe a little bit about the work that we're doing as part of Ascension Seton for this community, but then obviously in partnership with the CCC and many of the people in this room, and then leave some time for some questions as well, if the board has any. And so that's really my intent for today. I have no ask as well. This is purely informational from my perspective, if that would be okay.
Yes, sir.
So, great. So again, thank you for letting me be here. I joined Ascension Seton as President and CEO and Market Executive in August of 2017. Many people know Jesus Garza, who is my predecessor, who was actually wandering my building just a minute ago on the way over. And so I joined the organization after being in Houston with the Memorial Hermann Health System for about 20 years. And there were really 3 driving factors that prompted my interest in even considering the role. And one of them actually is this relationship. So I want to describe that. So my background over the past 20 years includes academic affiliations and academic partnerships, including serving as an associate dean at the University of Texas Medical School at Houston as part of my role as an executive with the Memorial Hermann Health System. And so I had academic experience, and given the new medical school relationship in this community, that was something that was both of interest of me personally as well as the search committee. The second would be that of running and being part of health systems, including a significant background in children's health care experience. Clearly an interest here as well. And then the third was the unique relationship that exists through the CCC, which I'll be honest, didn't fully appreciate or understand through the interview process, and I'm still learning through a pretty complex arrangement. But the entire idea and hope that organizations can come together and bring the best of themselves in a public-private partnership for all patients of a county, in this case Travis County, I thought was a pretty unique model and approach, and differed from my 20 years experience in Houston with the Harris Health System or the Harris County Hospital District, with an innovative approach to both maximize dollars into a county, have the appropriate partnerships, and then deploy the resources to impact a community in a different way. And so ultimately, I joined the organization, and have been working diligently, largely to fill our team where we had some leadership gaps, but then also understand the community and determine that how we can invest and be better partners to serve the Austin, Travis County area. I think many people know that we are part of Ascension, which is the largest Catholic not-for-profit health system in the country. And as part of that affiliation and our 115 years of serving this community, our mission statement calls boldly our desire to care for all people with a specific emphasis for the poor and the vulnerable that we serve. And that mission statement, which is on the back of my card and every piece of letterhead that we have, I think ties very well with the expectation, obligation of Central Health, and as that's played out through the CCC. And in my now 20 months here, a lot of the work that we've been doing across Ascension Seton, I would say, is 3 components. One is working on operational discipline so that we can ensure that we're running the business that is a healthcare operation and doing that efficiently, and being cognizant of reducing the total cost of care to the patients that we serve. The second is investing with our private physicians and the University of Texas Medical School, which is, as you know, just 3 years old, and bringing new talent and resources to this community and investing to build clinical programs. And the third is honestly working a lot with Mike and his team here to understand what we can do differently or in a bolder way to impact the patients and the community more broadly. And so over the course of the past several years, some investments that we've made, not in buildings per se, but in people, bringing new providers to this community and things like pediatric congenital heart surgery, adult children's, pediatric neurosciences, which is both have been pretty significant investments for us to do that. On the adult side, pretty significant investments as well in things like adult heart surgery, adult neurosciences. We just opened a new burn unit within the past year at Del Seaton Medical Center at the University of Texas, a service that didn't exist for this community that required burn patients likely to go to San Antonio, which has a fantastic burn facility. But this does allow us to keep patients and residents closer to home for the care that we're providing. Investing heavily in things like orthopedics and some in primary care and ambulatory locations as well. And so I say that not because of the investment we're making, but I think it's indicative of what we're trying to do in this community, is that when we're making investments in clinical programs and in physicians and in infrastructure, that supports all residents of this community, including those that we partner with through the CCC. And our desire and our goal is to have healthcare services with very deep clinical programs that will stand up nationally as it relates to clinical outcomes, patient safety, and quality. That's what we're after. And we have elements of that, but we're not there. We haven't arrived in any means to solve that in total. But that's the desire and the drive of what's behind some of our investments in recruitment of faculty at UT, as well as bringing new physicians into this community. We've been working very diligently with the CCC leadership as well to better understand the impact in the community, as well as some of the gaps that we have where we're not getting it done. And one of the things that I would like to see as part of our relationship is holding ourselves accountable to delivering outcomes and also having more transparency around what those outcomes are and what the relationship looks like through the benefit of really the partnership through the CCC, UT, and Ascension Seton for the benefit of the residents of Travis County. And I believe that this model, while complex, while new, offers a lot of hope for how public-private partnerships can look like in the future. And I believe that the relationship that we have with Central Health and the CCC can be a model for how this should take place across the country. We are fully committed and grateful for the relationship and the partnership. We believe it is completely in line with the mission of who we are, and that we are best positioned to work together as partners to impact this community in a different way. Having said that, it's tough. I mean, funding is a difficult component of the healthcare ecosystem right now. We have a population that's growing by about 150 people per day. And if you think about this relationship just 6-7 years ago as compared to now, the pressure that brings onto our ecosystem is real, and we have to solve that for sure. And not to mention, the entire healthcare landscape nationally and locally is changing dramatically before our eyes. I heard you asking questions earlier about outpatient physical therapy, care in home. So much of healthcare that is now being delivered is shifting from inpatient to outpatient, as well as direct to home.
That's right.
And we're working on pilot projects throughout Ascension, including admitting patients to home for healthcare, rather than an inpatient bed, with the expectation of delivering high quality care at a lower price point, lower cost of care. And so in the midst of all of those national landscape changes, it is impacting us locally as well. But that's for us as partners to solve. And I just want this board to hear directly from me that our team is committed to working together to find new solutions and caring for the patients that we're asked to serve in this community. The work's not easy. The solutions aren't always clear cut, but the partnership and the motivation is there to find ways to do it by maximizing funding into this region for us so that we can care for patients and families, but also to do it in a responsible way of both care delivery and the expectation of doing it in a way that is a responsible approach in reducing the total cost of care for the patients that we serve. So that's where we are today. I could speak for a long time about our strategies and the work that we're doing in this community. We've got a really solid team in place, and as you know, Ascension, Texas, which is how we refer to ourselves, is Ascension Seton in this market and Ascension Providence in Waco. and I have responsibility for those assets, so to speak, as relates to the healthcare delivery, including all of our other elements like our health plan and our physician group as well that are a part of that. So with that, I will stop. I'm happy to entertain any questions of the board. And again, I'm appreciative of the opportunity, Dr. Zamora, just to be able to visit and put a name with a face for one, and to hopefully continue to work together to find ways to meet the needs of our patients.
Thank you, Craig. I'm gonna go first.
Yes, thank you.
As this board has heard me say this many, many times, and as you said it yourself, it's about the patients. Because it's the right thing to do. We have to do our best, and you guys as well. You guys are doing a great job with our patients. But it's about the patients.
That's right.
Let's take good care of them. And with that, I know several of your staff. They're my friends, Willie, Geronimo, Katie. But the rest of the people I don't know, and I'm sure some of my board don't know them, so I'd like for them to introduce
Yeah,
themselves.
of course, yeah, thank you. We'll start with you.
Danielle Hall, Public Relations Manager, Ascension Seton.
Go ahead.
You too.
Geronimo Rodriguez, I serve as the Chief Advocacy Officer.
I'm Kate Garza, I'm Director of Advocacy.
Willie Lopez, Vice President of Public Health Alliances.
Scott Herndon, Chief Financial Officer for Ascension, Texas.
Thank you.
Thank you.
Welcome. All right, any questions, board?
I would just
First,
like to say thank you for taking the time, and we certainly appreciate you being here, and I certainly look forward to working with everyone for the best of those who we are serving in this community, so thank you.
Yeah, thank you, appreciate that.
Jen?
Could you just speak, having been in Houston, about the models that you saw there and the opportunities we have here, given the different structures of health districts there?
Yeah, absolutely, I appreciate that. And I was born in Houston, grew up in Houston, and worked there for 20 years, so that is my frame of reference. And I'm not trying to make Austin Healthcare that of Houston in any way, but Houston is interesting in that you have long-standing institutions like Memorial Hermann Hospital originally, it started in 1926. You have the Methodist Health System, St. Luke's, and then HCA are kind of the big health systems that are there. And you have a hospital district that historically was the Harris County Hospital District, now it's called the Harris Health System. And they own and operate two facilities. One is Ben Taub Hospital, which was right next door to the facility that I ran at Hermann Hospital for many years. And then another that's probably 6-7 miles away called LBJ. And then they had Quentin Meese, and then a partnership for a psychiatric hospital. Those were largely the hospitals that the Harris Health System had, in addition to a network of clinics that were staffed largely by UT faculty and Baylor College of Medicine faculty. And so the structure in Houston was UT, which happened to be the Hermann Hospital academic partner. They staffed our private hospitals, but the public hospital they staffed was LBJ. Baylor College of Medicine staffed Methodist historically until the divorce, and then they staffed St. Luke's facilities. And then their county facility they staffed was Ben Taub. And so that's how the ecosystem in healthcare was structured. But the thing that was interesting is I believe that health system as described is largely similar to most health systems across the country. But it does create many times a bifurcated health system, because you have a health system for the poor and the vulnerable, and then you have a health system for other patients, largely with a third-party payer. That's not completely accurate, but on the macro system, that is ultimately how the patient flow shuffled out in Houston. And Harris Health did a great job for what they had, but they had resource constraints and budgetary constraints and a commissioner's court that kind of was the directive for them. And it created consternation and struggle from time to time. I think we have the ability to create something different. And that different is that for every patient in this community, whether it's a CEO of an organization or a poor and the vulnerable, they have the expectation and the right and our expectation and obligation for that patient family to have the exact same care that you or I would have. And we haven't accomplished that. And we have gaps in our care delivery system now, but to me and our team, that is the hope of what we believe this partnership can accomplish. And it would create a pathway forward, and I think be a nice demonstration of how organizations differently structured, some public, some private, but with similar expectation of mission, could come together and do something differently. And so that's the difference, I would say, broadly between kind of the Houston model and what we have here. Clearly, size and scale is different given the population of Houston. But that is probably, to me, the most notable difference between the two structures.
The commitment is that we as partners will work to ensure that that quality of care is there that you talked about under this model versus what we have seen there in Harris County.
Completely agree, and I've had the same discussion with the leaderships of Dell Medical School, Senator Watson and others, that for me, the hope and the belief in this partnership is that. And it doesn't matter who you are or where you live or where you came from or what demographic or zip code, the expectation is high quality healthcare for all. And I think this partnership has the ability to do that. Yes.
So to be clear, and that was going to be my follow-up question, when you said bifurcated, what you're saying is that in what you saw in Harris County was there were two systems, and there were perhaps different levels of care, if I could say that, if you had private pay versus if you were going to the public hospital, and that's what you meant by bifurcated. And here, our goal is that it doesn't matter who you are demographically or whether you're private pay or public pay, you're going to get the same standard of care, right?
That's exactly right. And you know, I will just allude back to the investments that I spoke to of our investments in people and physicians and clinical programs. When we're building those for this city or this community, they're being built for all. And those same faculty that we're bringing in from across the country that are now housed at UT Dell Medical School and Dell Seton Medical Center at UT are seeing every patient that walks through that door, whether it's elective or emergent, regardless of payer status. And they are getting, and we are delivering in many cases, really extraordinary clinical care. I think there's a lot more that we could do. Thank you.
Manager Wallace?
Along the same line, and thank you for being here. We appreciate
Yeah,
you and
thank
your
you.
staff being here. But as we look at, as you said, it doesn't make a difference where you live and what resources you actually have access to. We want to provide the same level of quality care so that for all people. Well, the reality of us living in Travis County is that our population of poverty and color has been moved out of central Travis County and central Austin.
Yeah.
We've moved east, and there are very few resources available to them. We're having to struggle with the construction of clinics, the provision of care, therapists, doctors, professional offices that would be able to provide all the wraparound services necessary, the therapies and the this and that, the pharmacies, the laboratory, the need for laboratory equipment, to those populations, which is the majority of the people that we serve, according to statute. You are our partner. And yet, I don't remember seeing any Seton Clinic outside in the area that our poverty population is now located. Our population of greatest need is now located. And yet, I do know that most recently, and it's not under your watch, but there was a nice, maybe a mini hospital or clinic opened in West Austin. And if I'm not mistaken, I could ask for clarification. It doesn't make a difference, but the point is this. As we know that the community care system was created along 35, as we know that the hospital districts are, you know, basically here in central west of 35 locations, but our people in greatest need with least access to transportation, least access to resources are not. Is there any commitment that you would work with us to be able to address that need and construct whatever is necessary and to provide whatever services may be needed by our population?
Sure, I think it's a great question, and I don't disagree with anything that you had said. I think you might be referring to our Seton Express Care Clinic that was built in Westlake
Yes,
perhaps about
yes,
2 years ago. It's not a
yes.
hospital, but it is
Yeah, off of Bee Caves.
That's right, yeah. So I would say a couple of things to that. And again, you have to forgive me for being still new and not fully appreciating all the different components and some of our history. But I will say that healthcare, I'm going to go back to something I said earlier about healthcare is evolving and changing.
Right.
And there are several practices or FQHCs that we Seton have historically run that we have given over to FQHCs because that is their wheelhouse. That is what they do best. And so some of our partnerships with the CUC and community care and others, we were running that practice yesterday but felt it was in our best interest and the community's best interest for experts in FQHCs to run those facilities. And we have a few examples of that. And so whether it's us directly running that practice or that location, us being community partners through investing and providing resources, education, training, or us giving assets to other organizations, we're committed to all of Travis County. And again, I would be the first to say, we don't have it figured out. We have gaps in care now in our community, but collectively, it's to us to address.
There's our map.
Yes.
And if you were to superimpose
Yes.
Jason Fournier's CEO
Yes,
for
yeah,
Community
I know
Cares,
Jason.
if,
I do
map on where our needs, a population in greatest need is located,
Yes.
superimpose those two
It's
maps,
east-
and
east-
it
east also.
paints a really
Complete picture.
visual, where we are now and where we really need to go situation. I appreciate the fact that you also offer services for those outside of Travis County, because many of our population has been forced to move out of Travis County because they can't afford to live here. But we still have to deal with our population, and we have to do it by aligning all our services by all the partners. And it would be great to see that collaboration to the maximum extent be entered into. So,
Appreciate that feedback. One other comment I would make is that it's non-traditional, but this is a little bit where healthcare is moving as well. Ascension, and this predates me, but I've opened the facility, but we did open a pretty significantly different healthcare delivery facility about 18 months ago now, called Ascension Connect. It was also called Good Health Solution Center prior. Some of you may have seen or perhaps visited. It has a lot of different components in it, but one element that it does have is very significant capabilities for home health outreach.
yes,
It also has telemedicine and telepsychiatry for the members of the entire community that we serve. We've had some discussions with the CCC and Central Health about ensuring that that patient population has access real-time to
Right.
physicians and providers so that we can access and intervene earlier for patient care. And it's at a overall lower total cost of care. And we see a lot of significant both utility and upside in that platform. And there's a lot of other assets in that building. I just named 3. But there are other ways that we can reach families and be a resource to them as well outside of a lot of bricks and mortar. And it's going to be a combination of both.
where's that located?
It is, I don't know the exact address, it's basically adjacent to the outpatient VA Medical Center
Oh,
by
yes.
Bergstrom Airport.
Oh, okay.
It's in an otherwise nondescript retail space, or warehouse space with our Good Health Solution Center logo.
But that's a tie to the Del Valley, Elroy,
That's right.
Creedmoor, Mustang Ridge
That's right.
community, as opposed, I mean, not necessarily Imperial Valley or Austin Colony, but.
It's in their
but
backyard.
That's right.
That's right.
So
Yeah,
that's,
thank you.
I greatly appreciate you doing that, and I would love for you to advertise that more,
Okay,
so that our residents and our population in that area
It-
will know it exists, so that maybe they can better utilize it.
and that's part of the work we're doing through the partnership through the CCC and reconstituting what that agreement looks like and us bringing that resource for the CCC's use. So,
Great.
thank you.
Thank you very much. Thank all of y'all.
Any other questions, board? Mr. Hazel?
Yes, so just in quick and follow-up response to that question, we're talking about with all the federal changes and what's happening in the funding landscape, how the payment model should look, but also looking at long-term investments. And I think this speaks directly to your question, which is together, what can we do? And that's incumbent upon all of us here in this room to look very closely at what does it look like for 10, 15, 20 years in terms of where and how we need to be and what's the best way to be out there. And so that's something that we've already put placeholders in our discussions that we're having right now with CE. Second, and probably on a more professional note here, I would like to thank you because you have personally dedicated a lot of your time and attention, as well as countless hours from your team, into addressing these problems that, I shouldn't say problems, they're challenges, and all challenges can be overcome if you get the right brains and the right motive, and but also compassion for the people that we are privileged to care for. And so, thank you very much for, again, putting your personal
Thanks,
time
Mike,
and
and
attention
you-
to that of your team too. Thank you.
Sure, yeah, I mean, Mike and Jeff, Monica have been great. A lot of hard work ahead. Ultimately, I'd like to see us come out with both a joint strategic effort on how we can impact community, and then on the back end of that, have really community benefit report to demonstrate to the residents of Travis County kind of the impact that we're making collectively on behalf of them and with their investment. So, but thank you.
Thank you, Mr. Carter.
Yes, so thank you for the partnership.
One last comment, and that would be just as you talk about the development of that collaboration.
Yes.
And partnership, that we also talk about partnerships with respect to communicating the messaging, communication strategies that will reach out to those hard to reach and historically excluded populations.
So thank you.
No,
Thank you.
So this is an informational item, no action is necessary. My
you.
vice chair is going to take over for a second.
Okay, so, members, the next item that we are taking up, I believe, is number 3. Is that correct, Mr. Giesland, in the order?
Yes, it is.
Okay, so number 3 on your agenda. Let's wait a minute for the room to clear so we can have a little less noise. Okay, so item number 3, receive and discuss the report of the April 2019 financial statements for the Community Care Collaborative. This is an informational item.
Good evening, Lisa Owens, Central Health. So in your package, you have our Community Care Collaborative financials through April 30th. As a reminder, we do present these year to date. So just a few general highlights that are in your workbook. Cash is at $47 million compared to $63 million last year. And again, we've talked about this for the past several months. The timing difference on the DSRIP payment due to the CCC has impacted that, and that will be received later. Another DSRIP IGT will be received later this summer. Liabilities are at $21 million, and net assets at the end of April at $26 million. And then there was an increase in net assets from last month due to a Central Health member payment of $14 million. So briefly, just looking at the balance sheet, I mentioned the change in assets or cash, which is predominantly the assets of the CCC. Our total assets as of April 30th, 2019 are at $47 million. And our total liabilities, which are mainly provider contracts and payables for healthcare delivery, are at $21 million, and net assets, again, at $25.5 million. Our healthcare delivery summary, sources and uses. Year-to-date, sources of funds is at $76.8 million. As I mentioned, the $32 million has been received in DSRIP revenue, and a combined $39 million in member payments, and other sources being interest, totaling $76.8 million. Sources of funds. Our uses of funds at $56.2 million consists primarily of healthcare delivery for healthcare services outlined on the next couple slides, as well as our DSRIP project costs of about $8 million. And again, net sources over uses takes into consideration a $5 million emergency reserve, but our total net assets are at $25.5 million. Healthcare delivery, again, year-to-date totaling about $48 million. Is highlighted here. We have additional slides on primary care and specialty care. I will highlight, I believe, item 2 that you took up earlier this evening does address the high expenses in post-acute care at 80% of the year-to-date budget. We are at about 58% of the year. So we will make that adjustment, that amendment to the budget that you previously approved in next month, and you'll see that there. But as we've talked about in many previous conversations, we do anticipate being closer to that $2.2 million mark in the post-acute care this year. Our primary care expenditures year-to-date at $28 million. Year over year, you'll notice right on track with last year. And we are at 54% of the year-to-date. Again, primary care being a little bit more routine in the expenditures month to month. You will notice a little bit of a year-over-year difference in People's Community Clinic, a lot due to changes in that contract, pushing more performance measures that would come towards the end of the fiscal year based on performance. So again, primary care at about 54% of the year-to-date budget. Looking at specialty care, I'll just highlight a few things. Year-to-date, we have 36% of the budget, of the $10.6 million budget. And in the spaces where you see where it might be a little higher than the 58%, you'll notice that as the CCC has grown and the budget has matured and been more detailed, that we've made some changes such as community care, specialty care being budgeted in one line item last year, and now trying to break out those specialties in different line items this year. So in something like pulmonology, we may be a little over, but we would be under in other specialty cares that one of the providers where we were making those estimates is having expenses. So we don't anticipate any significant variances there by the providers and any issues with the contracts, but we were trying to be more specific to the type of specialty in the budget this year, and so you might notice a little over and under in that space. So again, $3.8 million in specialty care year to date. And finally, just looking at the healthcare delivery operations, again, the amended budget will change after the action this evening. You'll see that next month. This reflects the amendment that was made a couple months ago for the Front Steps contract, but we do have $12.36 million budgeted in our operations departments, and we are at about 36% of that, at about $4.5 million. And these departments provide all of the support for the healthcare delivery operations this year, and nothing out of the ordinary to report there. So with that, I can answer any questions.
Board? Andrew, all those?
I want to ask you about the last slide first.
Okay.
So on the last slide where you're talking about claims payment and analysis, and it's only at 19% of the budgeted amount, what's the reason for that? Is that going to be because we're going to move stuff over to post-acute care?
That is a newer department. Do you want to come? Here comes John. He's going to tell you about that.
Go, John. Go, John. Go, John.
But you'll see that that didn't have a year-to-date last year because that is a new department in this
Right.
budget.
There are actually two things in there. I mean, knowing that we were a bit short going into the year on some of our healthcare delivery budgets, over the course of the last 6 or 7 months, we've really been trying to take a look at our operating costs and identify opportunities for savings. One of those areas is we're approaching our actuarial study differently this year, and I think that's going to generate some savings for us, as well as just the time. Over the past year, we've been implementing this new TPA arrangement, and a lot of the volume is hitting towards the end of the year, so we are going to have some savings this year, but we're probably going to need to have that budget sustained going into FY20. Does that make sense? There's just
Yeah, it does.
there that has generated some savings for us.
So with respect,
700,000 of that is actually what we funded, what we moved into the item 2 that we took up this evening.
okay, so again, part of that is also the issue with the TPA, the billings. And it's correct.
It's been some savings associated with the change to the new TPA.
Okay, and with respect to the specialty care, I noticed that there's some, like musculoskeletal and pulmonology, but those things are going to regulate themselves by the end of the year. It just happens to be the month of the
So
slow.
We essentially took our best guess going into this budget of trying to what Lisa mentioned earlier, where we broke out the essentially aggregate community care, specialty care line. So that $2 million we had budgeted, we tried to take our best guess at what the utilization would be this year. So some of those are going to be a little bit higher, some of those are going to be a little bit lower from a contractual standpoint. They all kind of work together. And going into next year, we should have much better estimates so we can tighten up those actual service line amounts. But for example, you mentioned pulmonology. If we end up being slightly over on pulmonology but under in endocrinology, we can shift in our contract. We can shift.
But that was because endocrinology is also relatively new. Is that correct?
Those aren't new service lines, those are just newly broken out in the budget. So we're
Okay.
trying to get more granular to show you more detail in the specialty care space.
Okay, and then, had to ask the question. Since we just heard from Seton, I was looking at the member payment. The approved budget was 40 million, the actual is 15 million. That's on page 4. So the year-to-date of budget is 38%, and I'm just curious as to whether or not we have any hopes or think that that will move to what we expected in the approved budget from
So-
them?
As you know, the payments are based on the master service agreement, but we did receive we're in May, we did receive in May a $6 million member payment from Seton that you'll see
The
next month.
CCC? Just want to make sure.
That'll be reported on the May financials.
Thank you.
Question for Craig.
I almost asked. I
Forgot
was
about that.
going to, but I appreciate it. Thank you very much.
I have one question, and I'm looking, I'm like, your year-to-date and prior year-to-date numbers look spot on, so I don't think it's an issue. I think it's probably timing, but again, looking at community care, El Blen and Lone Star, you know, they're over, as a percentage of the year-to-date budget, they're over 50%, but we're only a third of the way into the year. So is that gonna, will that stay?
Start of the year going.
No,
We're
we're-
7 months into the year.
Yeah.
Oh, sorry.
October.
Duh. Okay, I'm thinking, yes, never mind.
Fiscal year.
All of that back. Okay, back.
It's not calendar year.
I'm totally thinking calendar. Thank you. No, it looks great then.
October.
Yeah, October, yeah.
Yeah. Any other questions? All right. This is
Thank
an-
you.
This is an informational item only, no action is necessary. But have a seat, Ms. Owens. You're coming up next.
I'll be here all night.
We love seeing you. Okay. Agenda item 4, receive and discuss a report of the April 2019 financial statements for Central Health. This is an informational item as well.
Okay, so, great highlights on our tax collection. As we get into April, as you know, the tax was due, January 31st. So, as we wind down the rest of the year, we'll see very little tax collection, but we do anticipate ending at 100%. We don't foresee any issues there, but we are at about 98% of the tax levy collected year to date. Other highlights are just that the intergovernmental transfer year to date is down again, going back to the presentation on the CCC. The timing on our DSRIP IGT did change without the program changes, and then also that Central Health did make a member payment to the CCC in April for $14 million. So looking at our balance sheet, no significant changes year over year. On our balance sheet, the total assets as of April are $394,000. Our current assets are at 160 million. Sorry, I said thousand, not million. Non-current is at 119 million. The variance there year over year would be the investment in Sendero through their risk-based capital and a surplus debenture. And then capital assets down year over year. Again, we haven't had a significant capital assets, and we have depreciation expense in that space. So again, total assets at $394 million. Liabilities, our current liabilities are at just $10.1 million. Year over year, I'd just like to highlight accounts payable. Last year at this time, we did have a member payment, not a member payment, a risk-based capital payment to Sendero that happened in early May, and so we did record that as a liability and as of April. And so that's where you're seeing a pretty significant difference in the accounts payable. And then in other payables, last year, there was, due to Seton, that was paid in the middle of the fiscal year, and so we do not have that liability this year, so our other payables are at just $90,000 this year. So the other thing year-over-year change is other deferred revenue. We did receive an early rent payment, so we just recorded that as a current liability. and that gets recognized immediately then in May. On our non-current liabilities, we also have deferred revenue there that is rent due from Block 164. You may recall we received 3 years of rent as part of that partnership, the lease with the 2033 fund. So the year 2 and 3 is recorded as a long-term deferred revenue. Total liabilities are at 18 million. Our net assets are at 375 million. Again, liabilities and net assets are at 394 million. Looking at our sources and uses for Central Health, fiscal year to date, at the bottom you will see we are at $119 million in sources over uses. Again, with most of our tax collection being complete, and 58% of the way through the year. We do have $5.7 million in revenue that did come in this month. Some of that property tax revenue. We do have lease revenue from Seton for the parking garage and the CEC, UT ground lease, and then again that first year of rent payment from Block 164. And we also received our tobacco settlement revenue this month of $3.5 million, which was well over what we estimated in our budget of $2 million. So again, total sources of funds this month, $5.7 million. We have 2 more slides on healthcare delivery, so I will skip that $16 million for the next slides, but our administrative program and our tax collection programs both are on track, again, where we would expect to be this year. We are at 40% on our administrative expenses. $3.7 million of our $9.3 million budget. And tax collection mirrors the tax revenue, so many of those fees are as collected, so that is not surprising to be at 91% of our budget. We will see the tax collection expenses slow down in the future months. Again, total uses of funds this month, $17 million, year to date, $141 million. We did make some changes to the slides this month to try to flow more in alignment with our budget as we get ready for budget season, which has begun. So we changed slides 6 and 7. All the same information is there, but a little bit more flowing in alignment with the budget. So you do see the intergovernmental transfer section first here. We do have fiscal year to date $77.9 million of intergovernmental transfers of our $139 million budget. Next, we have our provider cost in healthcare delivery, primary care. That is predominantly our Planned Parenthood primary care grant for the services that they provide. In addition, we had a member payment to the CCC, as we mentioned, of $14 million, and so our total provider costs being $14.2 million. And then service expansions funds, we broke out a little bit more information for you here, as we have started to have expenses for our sexual and reproductive health program, which is contracts that are providing LARCs to several providers for throughout the community. So you'll start to see some of those expenses in the next couple months as well. The slide continues on the next page with our healthcare delivery operating costs. Again, this is the departments that operate the healthcare delivery services at Central Health. We are at just 39% of our budget, $3.7 million out of our $9.5 million budget. And this month, we did have just over $560,000 in expenses. And then we have our other healthcare delivery costs, which includes 2 major initiatives that we've been working on for several years. The first being the campus redevelopment, $230,000 spent this month, just at 23% of the budget. And again, as I think you've heard many updates through the committee, but also here, the timing on these projects is not steady. And so while we do anticipate additional expenses, we don't know exactly when those will hit later in the year. And then our ACA enrollment and subsidy is, as we've started the year, is pretty steady, as we have the Central Health Assistance Premium Assistance Program and our new ACA High Risk Program with Sendero. So those are premiums that you see there this month of about $457,000 for both of those programs combined. Our total other costs there is just over $710,000, and total year to date at $5.8 million. The last section just shows the reserves. that were budgeted as uses of funds and just transfers that were made to those reserves or to the risk-based capital in previous months. And that just shows the reserves that have been allocated as a use of funds. Those total $23.8 million year to date. So our total healthcare delivery, again, for this month is at $16.6 million, and year to date is at $136 million. So with that, I can answer any questions about the central health plan.
Anders? Anders? None? Seeing none, this is an informational item. No action is necessary. Sorry, Ms. Owens. One more.
I just thought of one.
Okay.
It's just a real quick.
Manager Valdez.
So, taking into account that the LPPF passed, and I thought I read that it was, is it effective immediately? The only, well, no, but that's
Yeah.
not the point of the conversation. I'm using that as the preemptive for the comment, the question. When will we be able to see how that reflects with the other members in our budget? How is that going to occur? Or will this look differently? Will there be an additional page that addresses that?
So I don't
Because
know.
we'll be handling
We'll
the,
be
we'll be handling the
budgeting for-
administrative costs, we'll be
Right,
handling the
right,
administrative
so we
costs.
will be budgeting for.
And there will be IGTs.
Right, and we will be preparing that for you in next year's budget. The administrative costs incurred by Central Health will be part of the Central Health budget, but I'm gonna let Jeff jump in on
Mr. Knoll.
the LPPF budget.
Yeah, thank you. So one way to look at it, the LPPF is a separate structure.
Right, right.
Central Health's acting in a fiduciary capacity
Right.
for holding those funds.
Right.
So technically speaking, from a reporting, from a pure financial reporting perspective, we'll probably combine them all. I think for board reporting, we probably want to split that out. There'll be a lot of segregation and separation in all the things that we do. So for example, there'll be a separate bank account.
Right.
So when the funds flow, they're all segregated. So as far as the exact presentation format, I think we still need to work on that. But I would expect to see as we move forward some segregation, and we'll show separate reporting, like here's the cash on hand, here's how much we've IGT'd. And of course, in the rate setting process, you know, we'll have to give you some information related to what we project, just like a budget process, what we project as far as IGT requirements and the revenue requirements related around that. So it's kind of like you have a separate entity, but it'd all be rolled in technically on a financial reporting standpoint into the Central Health financial statements.
I think what I'm kind of referring to, and I didn't explain this very clearly, but the way I'm looking at it is that we're going to be part of a service delivery area. Okay, so there are going to be other counties that are going to be involved in utilizing our administrative strength and doing whatever. And I was curious as to whether or not it would make any sense for us to be able to differentiate between the different counties, how much money is going up and coming back for those counties. And the only reason I would be curious about the numbers is because as we look to resources that become available, since we're now looking in the bigger picture with respect to the other counties, who's there? What of our population is getting benefited? I'm not talking about our population necessarily Travis County, but I'm talking about our population needy, and how this is actually all working out with the other counties.
So I don't know how much of that detail we'll be able to provide,
Yeah.
but what I would tell you we will work on providing is, since we are part of a county Medicaid SDA, that we will work on gathering uncompensated care and any other programs that we participate in those areas, so that we can show kind of the local spend across the SDA, and then the amount of funds that were drawn from that. So it'll be a little work. You may have to bear with us a little bit, but as we progress on that, we will work, especially as we get towards the, closer towards the year end, we'll start gathering that information. and provide it.
I appreciate that. I just didn't know if it made any sense what I was asking, because we're new road to travel, so.
You'd like, I'm sorry, just to make sure that I'm on the same page, but you'd like to see, not just with what we're budgeting, but what's the pie that we're able to create?
That's right.
What's the size of the pie
That's
that
right.
we're able to create in terms of funding for healthcare through all these different mechanisms, whether we're the transferring entity or not, because under the LPPF, the hospitals are going to be that transferring entity. But is
Right,
that-
and.
I'm saying it a little bit differently.
Yeah,
I want
that's
to
right.
capture the theme of what you're trying to get
And
at.
in addition to that, since we're also the regional conduit under, what is it, 6? I think we're in Region 6, and we have many of the same counties that are included in that. I would be curious as to whether or not, as a region, we are
Manager Wallace.
taking in, anyway,
We
I
may be-
appreciate
We
that.
may be getting off of
Not for tonight.
not for tonight.
Thank
for
you.
Another day.
Thank you.
Jeff, Lisa.
Thank
All
you.
right. Agenda item 6, receive and discuss a report on the central health utilization of historically underutilized businesses, hubs. Again, this is an informational item. Ms. Lisa Owens.
My
Thank you,
colleague
Lisa.
Perla Cavazos.
And Perla. Welcome, Perla. Welcome, Lisa.
Okay. So you've had this information, and I'll just hit a few highlights and then leave it open for questions. And Perla's going to give an update on the outreach that we've been doing. But as you know, we have a purchasing policy, and in our purchasing policy, it states that we have a good faith effort must be utilized to assist historically underutilized businesses, hub, and I'm going to use the phrase hub going forward for historically underutilized businesses, vendors and contractors, and its award of contracts and subcontracts. So we refer to this as our good faith effort policy. The definition of a hub is clearly defined on the slide you see in the information, but that it's a for-profit entity in Texas that has at least 51% owned by an Asian Pacific American, Black American, Hispanic American, Native American, American woman, and/or service-disabled veteran. And then, again, they have to actively participate in the control of that entity. So the first thing that we do in our review of preparing our hub report is look at eligible and ineligible expenses, and those are outlined there. And so it's important to know that the percentages you see are on the eligible expenses, and those categories is where I'd like to focus on. And that's going to be things like heavy construction, special trade, commodities, which are tangible goods, professional services, and then other services. And those other services could be things like plumbing, consumables, and things like that. So we look at our eligible expenses to calculate our percentages every year. So for FY18, which had 154 million dollars in operating expenses. We had just over $5 million in eligible operating expenses that fell into that category I defined earlier. And of that, about 13.3% of those operating expenses were hubs. And then we also look at our CIP, our construction in progress, and these are things that are going to be capitalized at some point, or we think will be capitalized at some point, but they're in process, and we looked at that specifically, and again, that was about 13.87%. So the grand total for the FY18 was just over $774,000 in hub expenditures with an eligible expenditures of $5.8 million, and that put us at about 13.4%. So we always like to show you the comparison year over year, and we've highlighted this in the past. You'll notice that FY11 and FY15 are significantly higher with the eligible expenses, and that would, if you remember, were the years that we were doing heavy construction at North Central,
Yes.
as well as Southeast Health and Wellness. So as we have been in the past couple of years, not having such significant construction projects, although it's out there and it's going to be coming, those eligible expenses have gone down. But again, our percentage of hubs participating in our expenses has gone up just a little bit. Last year, we were at just about 9.9%. And this year, again, we're pleased to report just over 13%. We do like to compare to other entities, so we research and pull the most recent data available from some of our other government entities. And again, we feel like we are on par with some of the partners and even well in advance. But one thing to keep in mind is that our eligible expenses are, again, because of the type of the operations compared to the state of Texas, $20 billion, are $5.8 million of eligible expenditures. But again, we like to show that comparison. And then we also like to show you the comparison breakdown by type of hub. So we have them broken down there, and you'll see that about just over 6% is African American, about 31.5% Hispanic owned businesses, and 62% women owned businesses. And we have a 4-year look back, so we show you back to FY15 the results there for comparison. And I'm going to turn it over to Perla, who we presented to you in November about our hub outreach, and she's going to talk to you a little bit more about that.
Great, thank you, Lisa. So back in November, Yvonne and I came to you and presented, for just as an informational item, a hub outreach and engagement plan that we had put together. So I just want to give you a quick update on where we're at with that. We've been putting pieces together. We're doing a better job of, I believe, of speaking interdepartmentally of, contracts that are coming up. And we're trying to capture those upcoming contracts in a one-pager, especially now that, we expect contracts related to construction, Breckenridge and East Travis County to start getting into place. We're putting together a one-pager that summarizes those contracts and essentially tells hub businesses where to go to submit bids for that, which is BidSync. We are also in the process of updating our website with information, just improving the information on our website. And then also, we're excited about this, we will soon be entering into agreement with the Minority Chambers of Commerce, specifically to do outreach to hub businesses. So we're really excited about that. Actually, Mike and Yvonne and I met with the directors of each of the minority chambers earlier this year, so it's nice to see those contracts, soon to materialize. I saw a draft. I saw a draft copy. Yeah.
4 years coming, yay, in the making.
I would just echo Perla's comments. The interdepartmental strategies that we've put together are really exciting. We are working on our website. The procurement department does do procurement style fairs. We work with the city and the state, and we try to go to their fairs as they have much bigger and more robust programs. But we do use BidSync, which is just a way for people to be alerted. So the number one thing we can do is tell people to sign up for BidSync so that they get an alert. And then again, just make it easy for people to understand how to do business with Central Health. Again, getting them to BidSync to sign up, and checking our website, and then doing as much outreach and awareness as we can about upcoming types of procurements. So we're working hard on that. So just keep sharing your feedback, and we'll answer any questions.
Thank you.
Andrews? John?
What, are you able to identify, are these Travis County businesses, or are they outside of the county? Particularly as we look at those, the hubs particularly, are these organizational businesses that are based in Austin or Travis County?
I'd like to answer that, but I don't want to give you you a specific answer. I think most are, just in my recollection, but if you don't mind, I can look and specifically give you the information about, we have the list of who the hubs are that are in this category.
I was trying to get at, particularly now under the African-American one, 6.6%, I was just wondering, is that 6% of businesses that are from Austin, Travis County, or are they from other parts?
Yeah, and I just don't know the ownership structure of those entities off the top of my head, but I can certainly get it. Whether they're based in Dallas or,
Right.
they are Texas certified hubs. So, that is part of that, but I would need to look at the specific entities, and I can get that to you guys.
Thank you.
Manager Greenberg?
And does this also include subcontractors?
Yes.
Okay,
Yes, so if we have generally, again, in construction, we try to reach
Right.
out and ask for
Exactly.
subcontractor reporting. As we've had not that heavy of construction the past couple of years, that's smaller, but we do reach out to contractors with subs and ask for them for their reporting.
understood. And I know that, given that we have not been in a construction mode the past few years, that didn't come into play. But it might be helpful also when you look at how many or which ones or what percentage, however you want to slice and dice it, are locally owned, if they're the subs or if they're,
Okay.
because that might just provide us some more insight.
Guys, I think I got Manager Valdez, and then Manager Zuniga, and then Manager Oliver next. So Manager Valdez.
Thank you, Sheriff, for actually bringing up that comment, because that was one of the concerns I had. When we first started talking about looking at the hub numbers, one of the things that I specifically requested was how knowledge, or what is the central health process for, how do we weigh whether or not they are local businesses? To Manager Shannon's question, how are they weighted? Whether or not we have that in place, because that's one of the things that I know I asked for. And in addition to that, with respect to the subcontractors that contractors may have, I know historically, what I have seen with big contractors is that they say they're making a good faith effort, but there is no way to trace whether or not that's actually a real good faith effort. And so you will find that there are a lot of contracts that are not provided to hubs, subcontractors, because they'll say, well, we made a good faith effort, we didn't get anybody, and that's it. And so with respect to us, I would like to make sure that we have specific strategies in place to make sure that there's a follow-up with those that have received the contracts to make sure that it's more than really just we're saying that it's good faith, but it's an actuality. And if it's not, we'd at least like to know it or have access to that information. Thank you.
Manager Zuniga.
Sorry if you've already answered this before, since I'm new, I don't know. Women of color, are they captured under women, or are they captured under their ethnicity?
How they report. If they report as a woman-owned business, they would be captured as a woman. And if they report as a Hispanic-owned business, they
So
would.
we wouldn't be able to know.
I
It's
don't
okay.
think we have that level of detail, but this question has come up.
I
in
asked
your-
it.
Yeah,
I'm sure you would. I'm so sorry.
It's a certification that is not provided by our organization.
Right.
However, we can keep looking into that because it has come up in the past, so I can follow up on that.
And then my final question is looking at the change from 16 to 17 in African-American owned businesses, and that could have been a project that was over, but it went from just under 30% down to less than 10. Any insight into why?
I don't know specifically what the vendor breakdown was. And I'm looking at the year, I don't know specifically, but I can look. Okay.
I mean, it could have been a project that
Yes.
was complete, but, it would be great too if we could try to prioritize
I think it might have been HT.
first, and I don't know if this is something the vendor could do, but first, men and women of color owned businesses before, Caucasian women.
Manager Valdez.
With respect to that question, Julie, I'd like to know if you would be able to ascertain as to whether or not that might have been when they were doing the construction of the facility over at the HT campus or the Southeast Hub, because remember, yeah, I call it the hub, but it's the Southeast Health and Wellness Center, because they were, at the time, we were also talking about Rosewood, Saragossa, the creation of the clinic over at HT, et cetera, et cetera. And I didn't know if that might, the timing of those projects might have had anything to do with the numbers here.
There was a little wind down from those larger construction projects in FY16, but I can look at what vendors specifically.
And when I brought up, thank you, Julie, for bringing up that question. When I have brought that up in the past, I think that the response that I got was, legally, we cannot, Holly, if I'm not mistaken,
That's correct.
legally,
Yes.
we cannot ask that.
Right.
But so long, I would like to think that maybe we have a disclaimer, you know, with respect to those women-owned businesses, you know, to let them know, hey, even though you don't have to do this, we really would like to know whether or not you're Anglo, you know, Latino, African-American, whatever, Asian American.
So voluntary disclosure.
Voluntary
Right.
disclosure, yes.
Yeah.
I understand.
Yeah, I think that's the only way to go about it because it's self-reporting.
That's
But
right.
if it's, again, since it's self-reporting, if it's voluntary, then they can choose, again, a kind of a reminder of how they self-report.
Any other questions? If not, Mr. Giesman.
Yes, and I wanted to highlight this effort to reach out through the Chambers of Commerce and potentially other organizations. But, first of all, thank you for moving forward and making all this happen and work. And it has been a long time coming, but I want to stress something because this is something that the board members could also help us with in your contacts and your meetings that you go to. It doesn't have to be a Chamber of Commerce. One of the reasons why we're doing this is, yes, we want to say, hey, here's the mechanics of finding out about business opportunities, but we also want to earn trust. Trust is somebody that you want to do business with because the cause is right. And talk about how we're providing health care for 1 in 7 residents in Travis County. Talk about how we are wanting to expand in areas that are underserved. And even if you don't have a contract related to construction or to a particular consulting service that we're looking for at the time, just getting people to the point where they want to do business with us, where they want to sign up for those bid sync notices and go on the website, check us out at job fairs, et cetera. And there's a lot of relationship building that needs to be done, and you can't do it through bid sync. That's not the place to build relationships. And so to the extent that, you all have speaking engagements and people that you interact with on a regular basis, and, think about just what you know about Central Health. Just help us get that message out there, and that would certainly help to start building those relationships that are every bit as part of the business process as a transaction is. Thank you for indulging me.
Thank you.
No other questions?
I'd like to make one more suggestion, and I'm sorry. Historically, I have also talked about working with the city's economic development office and small business and women business owned department, and also with the quality of life commissions, as they hear from and communicate with entities that are out in the community, especially through the budget process. So,
Okay, this is an informational item, no action is necessary. Lisa, Cardinal, thank y'all for coming. Thank y'all. All right, agenda item 7, discuss and take appropriate action on healthcare services delivery expansion in eastern Travis County, including project budgets. Mr. Giesman's gonna open us up in an open session, but if we need to, we may go into executive session.
Thank you. Thank you, members. Members, in particular, I'd like to focus on the Kellum Road project this evening, and I'm going to call a quick audible, and if we could go ahead and put that timeline up there, and I'll speak to that. But I think for purposes of open session, I wanted to talk about where we are right now, and we had, again, best estimates back at the end of the year about when we might start some kind of facility construction or site location work out there. And my estimate at this point, and I think back then we were talking somewhere in summer of 2019, but I think that would be a stretch at this point. And I can go into more particulars on that later for financial reasons in closed session, because a lot of it involves clinical information from the clinical provider that we're working with out there that relates to financial planning information. But just as a quick refresher, during October, December time period of 2018, that's what I'm referring to as the period of intent and preliminary planning. We had staged an enterprise-wide project team to be able to answer a simple question. If we talk about being out in these areas, can we mitigate the risk that we won't be able to be out there? And it was you think about business deals the way they're done, you start having a bunch of conversations, and at some point you say, okay, if you're going to buy something, or we're going to have a merger and acquisition, or if we're going to partner together, you got to get a letter of intent in here. And so this was our way of doing that, of fulfilling that function, to say, okay, partners, are you in or you out on this thing? Because now we have to go to the next phase. And so that's what took us to January and March of 2019 of this year, where, again, for all four of the priority project areas, not just Kellum Road, we worked very diligently on making sure the ground leases said what they needed to say, or buying the mobile clinic, which has been purchased and we put into operation later this year, but also on a lot of the clinic planning that is necessary, understanding what levels of services, who's going to provide them, what scope of provider, but also start January through March, really getting into the numbers of things and understanding what your payer mix is going to look like. What are the first, second, third year operating expenditures going to be? What's the capital expenditures going to be? So a lot of the details on business, and there's a lot of going back and forth during this time period. About towards the end of March, the reason I put 3/21 is that's when I had a meeting with ESD and UT School of Nursing representatives. And up until this point in time, there have been conversations with community care, but I think there was the best way for me to sum this up is that the original clinical idea of having UT School of Nursing and ESD 11 work together was resurrected, in part because I think they identified some other funding sources that may be available in the future. And so, Jason, publicly, I want to thank you. Your team turned flips, and to be able to come to the table quickly. You met with the dean personally, and you brought a lot of resources to the table, and you're still at the ready if, for whatever reason, that we want to come back to those conversations. So thank you to Commissioner for doing that. But what we've done is we've had to quickly pivot and go back to the original concept. And this is right after I came on board. I remember ESD came to visit with the board. I think it was that summer, and
I remember.
The whole idea of having a paramedic and UT School of Nursing type partnership out there. So we've kind of come back full circle and come back to that. And wanting to be a good partner on this, given that that's the original arrangement that was brought to us, are giving that is every bit of due diligence as we can, and which brings us to the present. The due diligence period under the ground lease runs June 5 or June 6, I believe, but early June. And we have the ability to extend it if we need to. But I wanted to say we've gotten to a point where I know that the UT, at the higher levels in UT, that they're really looking at this, or really interested in working on this project. It's not just a little side project for the UT School of Nursing. I think it seems to me to be turning something bigger, which is a good thing that they've got that attention to it. But it may take us some more time on the due diligence piece, because we got to get the business model right. No one wants to go out there and not have a plan in place to make sure that there's a sustainable model of care out there. You all have been around when clinic operations have had to be wound down. In some cases, facilities moved, and that can be very disrupting to communities and patient care alike. But it's the patients, coming back to what's best for them, because that's what's in our the biggest thing on our radar right now. So I just wanted to kind of put some context around this, because it looks like there will probably be some delays, but some necessary delays to make sure that we're doing the proper diligence on this and giving UT School of Nursing ample time to work with our teams and putting something together. Along those lines, I'd like to commend CCC staff. I know John Morgan, you had a couple of project managers that we've dedicated to this, as well as other staff in the enterprise. The way we work these deals is, after December, we wanted the clinical providers in all of our 4 priority sites to start pulling us. Meaning, if you needed resources, or you needed to have conversations or decisions made, to be able to make something happen. So for example, getting the mobile clinic purchased, that we were working really in support of our clinical partners. And that's the way an enterprise should work. You should support the units that are out there in the field delivering care to patients. And so that's the approach we're taking here. We're supporting UT School of Nursing with whatever resources that they need. And that's a continual quality check on my part that I make at each one of our bi-weekly, now weekly meetings that we're having to them, getting that we're nearing the end of this due diligence period. So I'm happy to answer any questions based on what I've presented here.
Patrick Jones?
I want to make sure I understand exactly what you're saying there, because I got a picture that we have a lot of moving parts that are there, but there are some things on the ground. Can you sort of give me a picture of what is currently on the ground?
I'm sorry, I'm getting some strange feedback. Could you state the first part of your?
Yeah, I was just saying, you did a great job of helping us understand the dynamics of having to get to this point. What I'd be interested in, as of May the 22nd, what do we have on the ground in these areas?
Right. So we have a couple of things. One, the UT School of Nursing is already on the Del Valley ISD campus. As the crow flies, I'm going to say maybe a mile and a half, a mile, maybe 2 miles. I'm sorry, I went the wrong direction. Mile and a half, 2 miles. Don't quote me on the distance, but
Yeah,
but there's a challenge there because they can only see pediatric patients. They can't see families. And the original idea was, let's move that clinic to some space. Originally, we're talking about Elroy. It shifted to the property on Kellum Road. And the idea being, if you can start seeing families, that would be better. The community care just across 130 is operating out of the Travis County Employees Clinic 2 days out of the week plus Saturday hours. And I know that there's some conversations to hopefully get some additional days out there because they are at, or if not slightly above capacity right now. So we've got services that we provide. And then third, it's not a physical presence, but this gets back to some of the things Craig Cordello was talking about is, what are the different ways of connecting people with care? I know that if you're a patient at the Southeast Health and Wellness Center, you've had difficulty getting to your appointments. We have transportation programs that can go, if you're out there in that area and you're a Southeast Health and Wellness Center patient, that we can connect you with care that way. So those are the three things that I would point to. There's probably some other programs that I'm just maybe not catching right now off the top of my head. But
for the people who live in those areas, you're comfortable that they are aware of these initiatives that are currently underway in anticipation of what you talked about earlier, of where we hope to be in a few years or so.
We can always do more on the awareness piece. I know we push a lot of information out. We've recently, in one area of the county, we can replicate this in others, pending staff time and resources and funds to do it, but actually getting out and walking neighborhoods. I know in the Austin Colony, Hornsby Bend area with the home visit pilot, we either have just recently or about to have neighborhood walks where we've hired firms to go out and go door to door and let people know what services are out there. In addition to the usual media channels that Ted Shop runs, in addition to the community outreach events that we have, in addition to the community advisory committees that we use. And those are forums where we can disseminate information and push information out. The most recent one being out in the Creedmoor area that we had. So we use multimodal ways, but to your point, it just seems like we're never done with that work, and we're never satisfied that we've reached as many people as we can on that.
My last comment is that I'm only concerned, while we understand the dynamics of what you're working on, these timelines and getting things in place, the communities don't. And so for us to have a presence on the ground there and then seeing us doing these other activities, I think goes a long way to mitigating the issues of we're not there, we're not doing anything, they didn't hear us, that type of conversation.
Well, and that's why I wanted to talk to this committee first. We did at the last Southeast Community Advisory Committee, was that last week? We had that meeting. So we talked about this, and and then I needed to come back to this committee right here and have this conversation, but also I want to give UT School of Nursing plenty of room because they are putting together, it is a very complex business plan, and as soon as we get all these pieces into place and we've done all the diligence we need to do and and also made sound decisions in terms of the types of facilities that we construct and when, and that we locate, then I think we can have a more definitive announcement. I think in the immediate future, there's probably a couple of more conversations with UT School of Nursing and the ESD 11 before, and I think at that point, we'll be able to put together a little bit more definitive update. It may not be the final launch date or dirt turn date, or if we're gonna scale back and do something different for the community out there, or increase presence with other programs. But I think we will have an interim update, I would venture a guess, within the next 30-day window.
As long as these things are being done, I think it help mitigate some of the challenges.
Yeah.
Thank you, Manager Jones. Manager Alves.
Thank you, Manager Jones, for bringing that up, because for the people in the Eastern Crescent, you know, we took a vote and we made commitments, you know, almost, 2 years ago? 2 years ago, as we were coming into this budget process. And so for them, we were telling them at the time, if my memory serves me well, within this year or a year and a half, we're going to see activities so that you will be able to see that there's movement, that there's a commitment on our behalf and our partners' behalf to provide services. Not the children were already being served by the school in the school district by the School of Nursing. That was already in existence. What was happening soon after was the agreement with the Travis County facility located right there on the same complex where the Travis County Jail is. That's still in place. Those two things have existed almost all this time. And yet what I'm hearing is that there's still, you've been telling us that you were going to do this. We've been waiting and waiting. We're now going on our second and third budget discussion with respect to those areas that did not have access to a clinic, did not have transportation, did not have this, did not have that. Now, we have implemented rides, ride sharing, Lyft, whatever accommodations can be made to make sure that people get to our clinics. But with respect to what is located in their communities, what it appears to them is that all we've been doing is speaking, and we haven't done any action because we're still waiting for somebody to do something. The nursing school, which we know is already there, but I do understand 100%, and I've tried to tell them, well, there have been, you know, when you're talking about the construction, you're talking about legal contracts, you're talking about this, you're talking about that, all those things have to align. And so, you know, I can try and explain that to them, but there's still a high level of frustration. And so I would like to make sure, I don't know how many people are in attendance at these meetings, or whether that has dwindled. I can't answer that because I'm not there to be able to see historically what it's 2 years ago to now. Are they the same faces? Are they growing in numbers? Are they stopped going because they haven't seen any activity? That, I think, is an important thing to know. But with respect to everything else, the louder we can make our message heard to as many people as possible, you know, even if it means, you know, getting maybe interviewed, somebody gets interviewed, Dr. Samora, and having them putting out as a news PBS, what do you call it, a public service announcement.
PSA.
I think that we really should do that. And the same thing, not only with us, but with the other, you know,
Sure. I'd be happy
networks
to
or
work
whatever.
with our Vice President of Communications, Mr. Ted Burton, and
That would be
Ted,
a,
you got anything to say?
Actually, may I respond to Manager Waller's question? So,
Excuse me.
you know, first, you know, this is on me. I'll make that real clear. And I want to go back to early 2017, because this was born out of an idea. And I think there was a lot of discussion swirling around at that time around clinical presence and services. And let me just say as a quick aside, and I'll come back on message, but people are getting care out there now, even if it's not at the Travis County Employees Clinic, they're, when you look at, patients, and just kind of thinking about the community cares patients, or whether you map the entire CCC population, thousands of people in that southeast area of Travis County are getting care today. The problem is that it's not the most convenient locations for
That's
it.
right.
Now, that community care, and what's interesting is that how quickly you all reach capacity in that employees clinic just on the other side of 130 over there by the airport. So there is some means to get to that care, and then of course we can provide transportation if you're a Southeast Health and Wellness patient. You need a larger hub to go to. And then of course the clinic that UT School of Nursing has been running out there, gosh, for years. And so it's not ideal, but it is some. But anyway, coming back to this situation, the one thing that I've learned, if I could go back to 2017, is to have stepped back at that point and said, okay, let's look at all of Travis County, and let's look at what makes the most sense in terms of long-term capital investment, short-term, for example, like the mobile unit that we're doing, or the modular that we're putting in at ESD4 out of Austin Colony, Hornsby Bend. But the reality was we were responding in such a way that it was situational. It was based on, hey, what ideas being thrown at us? Yeah, this sounds good. Let's chase this thing. And I'll admit it was not the best business diligence. And again, I own all of that. But I think, I can't wind back the clock to 2017. We are where we are, and then publicly, this is the first step in terms of saying, look, I'm not sure I could tell you when a dirt turn date will be, or if we're going to do something completely different. That maybe UT School of Nursing and ESD 11 have some ideas in terms of what are some ways to fill some gaps in the meantime, while we're trying to figure out what this business model looks like. But my intent is to, Manager Jones, I hear what you're saying, push that information out there about what we are doing, but also to say publicly, hey, lesson learned, and this is on me.
I would like to just.
Well, let me respectfully disagree with you, Mr. Giesland. It's on me. I'm your chair. It should be on me to have gotten this through, and I'll be happy if Manager Valdez wants me to work with our communications department to tell the southeast area that we're working. I mean, we're doing our best. You guys are doing our best, because we have to make the numbers work. We have to have the places, the sites to be able to do this. So it's on me, not on you. Mr. Burton.
I just wanted to reiterate what we've discussed at our strategic planning meetings when it comes to communications. That we are using a comprehensive approach, as Mike mentioned. So from street teams on the ground to air cover, which is paid media, media relations. We are doing paid media now to promote events that are coming up this summer in our 4 priority areas. As we've told you, we are also in the process of launching a pilot project, which will put community health workers in the neighborhoods, on the streets, helping educate residents about programs, services, eligibility, and how to access care. And you asked about advisory committee meetings. Those continue. We made a decision to reduce the frequency of the meetings because we thought they were happening too often. But as Mike mentioned, we were in Creedmoor last week, and there was one resident who was there who had been in our budget meeting last summer, had been very critical about the pace of how services were coming to their community, and she had really changed her tune and was very appreciative and grateful for the fact that they are finally seeing activity and seeing action. So I just want to assure you that we are working with the advisory committees. We continue to email them regularly. We have a meeting Friday for the Colony Park Advisory Committee. So happy to provide more details when you need them, but just to assure you it's a comprehensive approach. It's not just hit and miss now and again.
Again, managers, this one's on me. This is not on Mr. Giesland. Yes, Manager Oliver.
And I want to kind of reiterate what you have said and what you've said. I mean, I've been on this board for 2 years, and the very first budget session was a very challenging budget session because we had people here every meeting saying, what are you going to do for us? What are you going to do for us? What are you going to do for us? And I thought at that one, we've allocated a good chunk of money for the next fiscal year. We'll have something. And I know we're working on stuff. I don't want to take away from, I know y'all are doing things behind the scenes that we don't see every day. However, one of the things I've asked for is that clinic that's there for 2 days a week, I've asked, is there a way to expand services to 2.5 days, 3 days, something that would be, I mean, even that can accommodate over time a lot of people, and I've never gotten an answer on that.
Dr. Fournier?
Well, actually, it has, and we did report to the board that it was expanded.
Maybe I wasn't here,
And
but,
it was pursuant to
Yes.
the,
It was increased to 3 days.
oh, I thought you said it was still 2 days.
no, it's
No.
2 days a week plus Saturday hours.
I can answer.
And then, I know that they're working on trying, well, they are in conversations with the county. I don't know where they are in terms of the process, but trying to get additional days at that clinic.
Manager Jones?
I just want to, I don't want to echo, I think we're all saying the same thing, we want the same thing. We just got the mobile van. How long will it be before it is up and up? Because people are visual. If they see that a mobile van with Central Health and Community Care are in their neighborhood, they'll begin to feel that, yes, things are happening. So we can speak to that, and the sooner we can get that out there, I think goes a long ways to helping them to see what we're talking about.
And so I'll be happy to share with you a schedule of events that we've worked on with Community Care concerning the mobile unit. But it'll start appearing in the community in June. And I believe services are scheduled to begin on June 24th, I think. I may have that date wrong, but there are several events where the van will show up. It will be providing healthcare services, but it'll provide health screenings. But again, letting the community know it's there so they can get accustomed to seeing it and touring it. And then we'll have official ribbon cuttings in Colony Park and Creedmoor at the end of June, and we'll let you know those dates. I think it's the 20th and 24th, but I may be wrong. But we'll get that to you.
And I think that will go a long way for people to
Absolutely.
begin to see some action as well. So.
Manager Rondos?
Just to follow up, thank you very much, because I would love to see that van going through the neighborhood, driving through the neighborhoods and stopping in a spot, you know. With respect to maybe another opportunity to message to those communities in Travis County Precinct Number 1 and Travis County Precinct Number 4 is to make sure that there's some events with our county commissioners who continue to have meetings out there with their constituents, because that's what they do. And so maybe it would be a good idea for our Central Health team, or Dr. Samoda and Mike and whomever, to be there when Travis County, when Jeff is out there and when Margaret is out there, because we have to thank Commissioner Margaret Gomez for having worked with the EMS people and helping to make sure that this happened. And I personally want to thank her, as my county commissioner, for making sure that that did happen. But with respect to what Commissioner Jeffrey Trevelyan has advocated for and supported with the Colony Park and the other area, the expansions in Manor, along 2 and Harris Branch, along 290, et cetera, and then Margaret over here, in an area that doesn't even have a lot of times access to good roadways. So this is, in Precinct 4, there's a major deficit of resources and services. And so I think it would behoove us, you know, to start maybe looking at trying to do some of those events or aligned meetings or unveilings with our commissioners in those two
Commissioner
areas.
Gomez was at our meeting last week in
Right, I know.
Creedmoor, and
I
she's
know.
going to be joining us for one of the ribbon cuttings as well.
Good.
So we've been in communications with her office.
I was talking about like joint press conferences or something. You know, here, we want to shine a light.
We're doing
We
that.
are
That's
working
the
on
plan.
this. Thank you.
I'd be happy to show it. Manager Rondos?
Share that with us.
Vice Chair?
I have a quick specific question. I may have missed this when you were talking about the Creedmoor and the mobile van. You said that there was a woman who had been rightfully quite concerned the year before about service and when she would get it, and that she was happy to see the progress. What progress was she speaking of in Creedmoor? And do we know yet a schedule for that mobile van, you know, how often and the frequency or anything like that?
We do. We have, and we've published that. We have flyers that we're distributing.
that's what I
So
thought.
again, we'll make sure that you have those.
Good.
But the schedule is already set and published, and we're getting that out there everywhere that we can.
Good.
And I think she was, and I don't want to put words in her mouth,
No,
but
I
she
don't want
was just, I think, pleased that we're making progress. Mike was there, and that she acknowledged it has taken longer than perhaps a lot of us
Right.
wished it had, but I think they're happy they're seeing some progress.
So they are getting the flyers with the schedules and
Absolutely.
Okay.
Distributing through the school district.
Yes.
Any way we can.
Yes, that's right. Backpack, student backpack.
Manager, did you get that? See your hand?
Yes.
I decided that it's at a different time, we'll be
Manager Jones.
Come on, speak out.
Well, I just wanted to report on the School of Nursing, and
Oh.
if it's not appropriate, you can let me know. But they're gonna be doing household level assessment, so instead of just being wide, it'll be in their homes and assessing. And it's been done in other regions in Austin, so this will be.
That's right.
So they'll be in their houses
Good.
soon. It looks like they have the
Great.
the questionnaire all ready to go. It's a little bit longer than we want, so they're headed.
Yeah, that's always an issue.
Assessing resources.
Yeah,
Thank you,
so it'll be a
Manager.
little more, it won't be big, it'll be little.
Thank you. Manager Jones.
I just piggyback off of what Manager Valdez said, in terms of us being visible with commissioners. This past Saturday, I think it was Saturday, in Manor, the commissioner had a town hall meeting. We were not part of the organizing, I think we did have people there. But I think we need to participate in those kinds of things because we get a broader breadth, and Commissioner Trevelyan should be committed because this is his third one, I think, in his district. And so I think we need to be visible there because we get a lot of more bang for our buck as well in terms of political as well as community buy-in.
And I would be, as I told Manager Valdez, I would be happy to show up and be our representative. Excuse me?
And I will add that I'll be happy if there are times that you cannot, just, contact me and I'll do whatever I can.
Members, if there's no more questions, I forgot a
Yeah.
point regarding construction. Right now, we have enough information, through the due diligence process, we feel like that in terms of construction, we can make something fit out there. And it's not just a building, but it's the parking, it's the walkways, it's the septic system because they're not on
Right.
a common sanitary sewer, so you gotta put in a commercial grade septic system. And then obviously doing water hookup utilities. With respect to construction, and I'm gonna overly generalize it just to give you a sense. We still need to work with the ESD on terms of sequencing because they still gotta start their fire station and they're still in the permitting process at this point or figuring that out. But, we don't wanna be in their way, but at the same time, there's some common infrastructure that needs to be put in on or about the same time, for example, driveways into the property. And so, but that's what I would say construction side coordination, but for the most part, in terms of looking at the property and figuring out, okay, can we put something out there that's gonna work for a clinic? The short answer is yes, we got that part figured out.
Any other questions, managers?
Thank y'all.
Thank you.
Anything else, Mr. Eason?
No,
Thank
that's
you.
part, no, sir.
All right. All right. I guess we're finished up with.
It looks like.
Close session.
We need to go to closed session. All right.
Oh, okay.
I announce that the committee is going to convene in closed session to discuss agenda item 7 under section 551.085 of the Texas Government Code, governing board of certain providers of healthcare services.
It's item number 7, you said?
Item number 7.
Okay.
And it is 7:30? Let's take a 5-minute break.
And if I could request,
But it's gonna be.
Lisa and John Morgan.
Here,
Stay in closed session.
What about Jason?
No, John Morgan.
Let's take a quick
gonna be something about, the fact that we had Rosewood Zaragoza and a possible, its closure, and the conversation with respect to the HT clinic. Holly.
Council- All right, so it is 8:34, we're coming out of closed session, and I do not need to read agenda item 7, Holly? Okay, all right. All right, let's go to agenda item 11, confirm the next regular committee meeting time and location. The Central Health Board of Managers Budget and Finance Committee meeting is scheduled for June 19th, 2019, at 5:30 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. Do I hear?
I move adjournment.
Okay.
You have a second of that person? All in favor, say aye.
Aye.
Thank you, members.
Got that one down.
So with respect
Everybody's
to
favorite.
clinics,